Good morning and good afternoon. Okay. We have three lectures for this afternoon, and we will be talking about maternal and child health, immunizations, and breast. So we have reproductive health. First. We have reproductive health closely intertwined for this afternoon. We have maternal and child health and closely intertwined because it's one of the um, sustainable development goals, which would be heavily invested in maternal mortality and child health and under five mortality. And maternal looking at maternal health as well as immunization and breastfeeding would be one of the strategies at the forefront of making sure that both mother and child are healthy. Because if we have healthy mothers, definitely we will have healthy children. You have learned earlier in your obstetrics class that if antenatally, there are health problems in the mother, more often than not, your children would also be sickly, would also have infection, would have um, diseases passed down to them when their mothers are not at the optimal health during pregnancy. Okay? So health, mother and child, of course, if these two are not healthy, then we will not have a healthy society either. So remember our SDGs? Okay? What strongly inculcated would be mother and child um, roles as well as gender roles and all encompassing for your sustainable development goals for our purposes. Okay. We go back to the definition of health. Okay. Complete physical, mental, and social well-being state, and not only the absence of disease or ailment. That's been defined by WHO as how we define health. So this conforms to the idea that health would encompass everything. Although globally there are a lot of difference between age, between culture, between boundaries, gender. Okay, this would be a universal definition, okay, for what we look at health. Okay. And this cannot exist independently, and it is interdependent. Your physical, your mental, social health, some would even add spiritual, so that the four pillars would balance life so that we can achieve maximal productivity. Okay, we cannot just foster physical strength, but we don't have mental aptitude. We cannot be intelligent, but we are not social beings. We cannot be um, social but no emotion. Okay, so there's a balance, and it's interconnected between one another. Same way, disease exists simultaneously, okay, only if the health is defined restrictively. But you know that that's not the case. So what does that mean? So you will often see, you studied them one by one. Pregnancy, hypertension, diabetic, asthma, etc. And so all other disease states that you have learned in medicine, pediatrics, and the like. Okay. But in the real world, it can exist all at the same time. It can be pregnant, hypertensive, diabetic, asthmatic, all rolled into one. All problems listed. Okay? So it's important because you have to, again, go back. You haven't had your community organizing lectures, but you have to prioritize what is life saving or what's the most pressing issue. Okay? That's why there is a chief complaint. There's reasons why people, why patients come to you. But you have to check for all. Okay? Get wet. Okay. Okay. Remember your first year. Okay. Health and disease is determined by a lot of factors. So you have your biomedical factors, psychosocial factors rolled into one. Okay, so biopsychosocial aspects of disease. And sometimes it's not just the biological aspect that we see, but also your other psychosocial aspects, something like this. Okay, some are associated with poverty, low levels of education. Okay. Individual health is affected by individual factors. Okay. For the person, so each choice that an individual makes affects your health, whether you're a smoker, your diet, your cultural values. Of course, also affected would be your economic, the health services that's available to you have direct implications on the individual. Okay. We go back to public health. You have learned public health is to promote health, to prevent diseases, and to prolong the life through organized efforts of the society. Okay. The gains in health have been obtained as a result of improvements in the economic, income, education, water provision, s- nutrition, hygiene. So a lot of services and the result of new knowledge. So for the cause, prevention, and treatment of diseases. So with primary health care, most especially, you have these services all in the realm under the realm of public health. Okay. That's why for your third year, we talk about pollution, food sanitation, and the like. Okay. And not just disease entities. Okay. So maternal and child health is also central to this, would benefit from monitoring and investigation, would benefit from health promotion, social participation and empowerment, development of policies and capacity of management, evaluation and promotion of the equitable access to services, and quality of health services, research and development, and reduction of emergencies and disasters. Okay? Population health monitoring and analysis, such that changes in demography, changes in epidemiology, the changes in technology, basically the environment could affect disease. Okay. Public health is affected by sanitation, okay, and would produce morbidity and mortality, would produce your inequities, emergent to emergent diseases, would affect reproductive health. And thereby, this would affect the maternal and child health care both because it will affect access, it would affect nutrition, and drastically affect maternal child morbidity and mortality. And this poses a problem. Okay, so what are the challenges with as far as maternal and child health and public health is concerned? Okay, some sanitary challenges would require new strategy to prevent disease appearance and promote total development of health. For example, happened to COVID? We had to develop new measures so that we can control the outbreak. So this would exist through to there's priority of disease treatment services by primary prevention of diseases and what is urgent. Okay. And unfortunately, what took a backseat during the pandemic situation was reproductive health. Okay. So funds were channeled to combat COVID. Okay. And one of the collateral damage would be funds for reproductive health. So what would reproductive health processes, functions, and system? Okay, so this applies to people are able to have a responsible, satisfying, and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. The problem with the situation of the pandemic, people were locked down. Some were locked down with partners that weren't safe. Some were locked down without any form of contraception, without any choice of family planning. So those were obvious collateral damage as far as reproductive health is concerned. And it was at the back of our heads because the priority was a more urgent concern, which was controlling the outbreak. And what was the secondary outbreak joke? It was a running joke among obstetricians. Every time there was a lockdown, there would be an increase in number of births after 9 months of the lockdown. For example, March was a lockdown. That December, January, people were getting, babies were getting delivered. Same way, September, somewhere May, June, babies were getting delivered because those were the total lockdowns imposed. Okay. So there's an implicit right to be informed of and to have access to safe, effective, and affordable and acceptable methods of fertility regulation of their choice. So we should have access to appropriate healthcare services to go safely through pregnancy and childbirth and provide couples with the best chance of having a healthy infant. Okay. Again, it was compromised during the pandemic because you don't allow people to go out. Okay. So as far as reproductive health care is concerned, we have your social determinants of health coupled with your health services, coupled with your environmental factor, your genetics factor, health promotion and prevention, all encompassing what we know as reproductive health, maternal child health, and would drastically affect morbidity and mortality. Okay, so what is maternal health then? Okay, maternal health is women during pregnancy, childbirth, and the postpartum period. Okay, so motherhood, so associated with suffering, ill health, and death. Okay, like it or not, even despite technology, maternal mortality remains high because when you get pregnant, you don't know what will happen. Even if you have prenatal care, you could go into hemorrhage once you deliver. Top bleeding would be still hemorrhage, infection, and hypertension. That is still coupled with the presence of unsafe abortion, okay, obstructed labor. So these are direct causes of maternal morbidity and mortality. Okay, so maternal health care, so that's maternal health during pregnancy, childbirth, and the postpartum period. But maternal health care would encompass more your family planning, even preconception, prenatal, and postnatal care. Their goals would be to provide education, health promotion, screening, interventions for women of reproductive age to reduce risk factors that affect future pregnancies. Okay. Prenatal care is, on the other hand, is the comprehensive care that women receive and provide for themselves throughout their pregnancy. Okay, women who begin prenatal care early in their pregnancies have been shown to have better birth outcomes than women who receive little or no care during their pregnancies. More especially for those who have had second, third, and fourth children, they don't value prenatal care as much as the first baby. Okay, but that is wrong. Whenever we have a pregnancy, it's different. Okay, so you will have better outcomes if you will have prenatal care. Postnatal care. Issues include recovery from childbirth, concerns about newborn care, nutrition, breastfeeding, family planning. Okay, this is important, especially the time after delivery is very crucial, especially for the newborn and mother for the first 24 hours. Because not only because two-thirds of all maternal deaths occur in this postnatal period, but the attention drastically shifts from the baby, from the mother. Oh, you're pregnant, but when will you deliver, etc., etc. And then there were two. After delivery, where is the attention? More often than not, it's with the baby. Oh, the baby is so cute. Oh, who does it look after? Mothers forgot it. Mother had labor at least 24 hours, very tired and very emotional about what she went through. And we forget the mother delivering, having pain, undergoing pain to deliver a baby. And after that, everyone's attention from the husband to the parents to everyone, leaving no one to attend to the needs of the postpartum mother. So don't forget, your mother is as important as the baby delivered. Same way when you have families and you're a male, your wife is as important as the child that she delivered for you. Okay? In developing countries, more especially, most women will not have access to healthcare, would not have access to sexual health education services. And what will this mean? Basic services would be hard to come by. What do I mean by this? Sometimes, like in India, some would have access to sanitary napkins. Okay? So, in developed countries, excuse me, in developed countries, the risk of dying is higher than in the developed countries. Of course, the disparity between poor and rich is highest as far as indicators are concerned would be maternal mortality. Okay. At the level of preconception and prenatal care, you have your complications in childbirth. Still, leading causes of death among women of reproductive age. Why? Because for the longest time, what? Home births are allowed. Okay, in the Philippines, it's only been recent that home births were disallowed and you have to deliver in an institution. And less than 1% of these deaths would occur in developed countries, showing that if there are resources and services available, again, maternal mortality and morbidity, although not always preventable, could be drastically reduced. There are birth-related disabilities also that can affect women. Okay. That's why some would prefer cesarean section because your pelvic muscles, organs are affected. Okay. But better vaginal delivery than cesarean section. And at least 20% of the burden of disease in children below 5 is related to poor maternal health and nutrition, as well as quality of care of delivery during the newborn period. So, children are sick because their mothers were not healthy during conception, or the care given them during delivery was not enough. Yearly, 8 million babies die before or during delivery or in the first week of life. Okay. Consequently, children are left motherless each year as there's maternal mortality occurring. Okay. If their mothers die on childbirth, these children are 10 times more likely to die within 2 years of their mother's death. Okay. So maternal and child health and disease has multi-factor origin and can exist of sequential and continuous form. Okay. So some conditions account for the fourth leading cause of death for women after HIV, malaria, tuberculosis, and the like. Okay. So what is maternal death as defined? Death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy or cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. Okay. Burden of maternal mortality is an important input to health decision making. So as long as it's within 42 days, not from an accident, it's considered maternal death, even if it's not the direct cause. For example, you died of cancer, but you delivered 7 days prior. That's maternal death. Okay? Or the like. Okay. And it's a global burden because loss of health due to pregnancy and to these risk factors would be abundant. Okay, you have your disability adjusted life year that combines years of life lost due to premature mortality. Of course, people who get pregnant are quite young. Some would get pregnant at early teens, 20s. Okay? So, of course, you have years ahead of you. So that would be your disability adjusted life year, especially if something happens or loss of life occurs. So that we can identify the maternal deaths in circumstances in which cause of death attribution is inadequate, a new category has been introduced. And this is pregnancy related death. So this is defined as the death of women while pregnant of within 42 days of termination of pregnancy, irrespective of the cause of death. Okay. So maternal mortality ratio by country. So sorry, this is an old figure. Uh, 15 years ago. So what's red in Africa? Okay. Um, India and the Philippines would be colored yellow. So that's 200 per 499 childbirths. Okay. So green would be the developed countries, etc., etc. Okay. So we have to lessen the disparity because in Africa and Asian countries, maternal death per 100,000 live birth remains only. Okay. Maternal mortality. So there's critical indicator of population health reflecting the overall state of maternal health as well as quality and accessibility of available of primary health care that's available to pregnant women and infants. Okay. How's maternal mortality ratio measured? It's per 100,000 live births. Cool. However, to measure it would be accurately would be difficult, except where if there's comprehensive registration of deaths and of causes of death exists. Okay. Maternal deaths are clustered around the intrapartum, labor, delivery, and the immediate postpartum. And again, the most common direct cause globally is obstetric hemorrhage. The other causes, anemia, sepsis, obstruction of labor, hypertension, and unsafe abortions. Okay, what are the risks? Okay, risks are increased as the frequency increases of birth, spacing of births are decreased. If there's under or overnutrition with women putting off pregnancy later, you have your stature and maternal age. The availability and appropriate medical and midwife support, access to emergency and intensive treatment if necessary. So lack of management capacity in the health system. There's no political will and lack of management capacity in the health system. Okay. Maternal death risk. So another risk to expectant women is malaria. It can lead to anemia, which increases the risk of health problems for babies. Okay, a majority of these deaths or disabilities are preventable, being mainly due to insufficient care during pregnancy and delivery. Okay. You have maternal death risk. So HIV is an increasing threat. Mother-to-child transmission continues to be a major problem, with up to 45% of HIV-infected mothers transmitting infection to their children. Furthermore, HIV is becoming a major cause of maternal mortality in highly affected countries in southern Africa, especially with the emergence of tuberculosis. Okay. Child health. Well, it would have your physical, mental, and social well-being as well. Okay. Each year, more than 10 million children under 5 will die. Okay. With 6.6 million child deaths preventable if affordable health interventions are made available to the mothers and children who need them. Okay. And what would be the underlying causes of child illness and death? Most would be linked with poverty, with more than 200 million children under 5 live in absolute poverty on less than $1 per day. So that is around 55 pesos per day, or around 50 lakhs per day. Undernutrition and malnutrition. If ever they eat, they're eating incorrectly. At least 200 million children under 5 are malnourished. Okay, sometimes we just eat empty calories, junk food, or noodles and rice with no source of protein. Okay, and that will lead to undernutrition. And of course, because of high fertility and short birth intervals, frequency and spacing would be high in developing countries. On the other hand, developed countries would rarely have babies, thereby they would have population contraction. But again, that's another problem. Okay. So this poverty nutrition problem would bring about indicators, would affect indicators. And one critical indicator would be infant mortality. So this reflects the overall state of maternal health as well as the quality and accessibility of primary health care available to pregnant women and infants. So infant mortality rate, number of infant deaths per 1,000 live births in a population. Okay. Other indicators. You have neonatal death. So that's death of an infant less than 28 days. So these are your indicators. Post-neonatal death, death within 28 days and 1 year after birth, low birth weight less than 2,500 grams, and very low birth weight with 1,500 grams. Okay. So this infant mortality rate is made up of two components. So neonatal, first 28 days of life, and post-neonatal, first year. Okay. What's the leading cause of neonatal death? So this would include birth defects, disorders related to short gestation and low birth weight, and pregnancy complications. Okay. Most are preventable, especially those related to preterm birth and low birth weight, which would be approximately 20% of neonatal deaths. Okay. This post-neonatal death reflects events that experience in infancy, including SIDS, birth defects, injuries, and homicide. And SIDS is the leading cause of post-neonatal death. That's the sudden infant death syndrome. Most deaths usually occur first 24 hours of life. 3/4 of neonatal deaths occur in the first week after birth. Okay. So what are these diseases? Preventable at that. Okay. These are avoidable during pregnancy, labor, and postpartum. Okay. If you have screening, congenital screen, so that you know any genetic disorders. If you have your prenatal checkup, you know if the patient has infection, syphilis, rubella, chickenpox, which can be passed on to the baby, or HIV. If patient is diabetic or hypertension, there are other complications associated as well. So prenatal care would be very important in affecting neonatal mortality because it's the first 24 hours of life. Again, preventable and affordable. You don't need much technology or much effort to prevent this disease, these deaths. As I've mentioned, health of infants would largely depend on health in utero. If fetus with severe defects or growth problems may not be delivered alive. Okay. Because only live births are counted in infant mortality rates, perinatal and fetal mortality rates provide a more complete picture of perinatal health than does the infant mortality rate alone. So you have your indicators of perinatal and fetal mortality rates as well. So what is perinatal mortality? Perinatal mortality includes both deaths of live-born infants through the first 7 days of life and fetal deaths after 28 weeks of gestation. Okay, this is a useful measure of perinatal health and the quality of health care provided to pregnant women and newborns. Okay, fetal death, on the other hand, is associated with maternal complications of pregnancy, okay, such as problems with amniotic fluid, cord disorders, blood disorders. Also, when there are birth defects such as anencephalus, renal agenesis, and hydrocephalus are present, some of this would not be, or most of this would not be compatible with life. These rates of fetal mortality are 35% greater than average in women who use tobacco during pregnancy and 77% higher in women who use alcohol. So to target prenatal risk screening and intervention to high-risk groups is critical to reducing this gap. So this would be missed calls. So this would be stillbirth. Okay, information about 4 million deaths is limited. So even information on stillbirths, there are no systemic global estimates. The numbers are high and regions in which most stillbirths occur are a challenge because underreporting is an issue. Okay. Another indicator would be under 5 mortality rate. So it indicates the probability of dying between birth and 5 years of age. So this is expressed per 1,000 live births and is subject to current mortality rates. So it's has several advantages as a barometer of a child well-being in general and child health in particular. It measures an outcome of the development process. Okay. So it's a wide variety of input result of nutrition, level of immunization, which we will discuss later, availability of maternal and child health services, which will also include prenatal care, income and food availability in the family, safe drinking water, child safety, And this is less susceptible to the fallacy truth that it is picture of the health status of the majority of children. Okay. So they say children less than 5 years mortality, 80% of all child deaths would be due to the following. So pneumonia, diarrhea, malaria, pneumonia preterm birth, asphyxia at birth, measles, HIV. So most would be infection related, which are preventable. But again, it's not singular. So most would have a lot of causes. Remember the story of Rosario. Had infection, also had nutrition, had other social factors, which caused the death of the patient. So it's pluripathologic causes every time. Okay. Such that even if your Millennium Development Goals and your Sustainable Development Goals aims to reduce global maternal mortality rate to less than 70 to 100,000 live births. If you will remember your um, graphic, India and the Philippines would fall under 200 to 499 per 100,000 live births. So we're still far off. Such that we end preventable deaths of newborns and children under 5, with all countries aiming to reduce neonatal mortality to at least as low as 12 per 1,000 live births and under 5 mortality rate to at least as low as 25 to 1,000 live births. And with universal health care, ensure universal access to sexual and reproductive health care services and its integration into national strategies and programs. Some facts. 17,000 fewer children die each day, but 6 million still die before the age of 5. Okay, measles have prevented a lot of deaths. 80% of death would occur in Saharan Africa and Southeast Asia. Children in poverty are 2 times likely to die. And if you have an educated mother, you're more likely to survive. Okay. Remember Rosario. Rosario's mother was not educated. Although maternal mortality has fallen by almost 50%. Okay. Declining by as much as 2/3 in East Asia, North Africa, and South Asia. But still higher in developing countries. Only 65% more women are able to receive antenatal care. There are fewer teen developed countries. And the need for family planning is slowly being met. So again, our small steps to improve maternal mortality and child health. Okay, maternal health and child health. But we have a long way to go. Okay, some continuing problems, re-emerging problems, even with COVID, HIV, dengue, cholera outbreaks, avian flu, war, bad governments, and ineffective policies. So preventive interventions, remember vaccination, supplementation, tetanus toxoid, screening for syphilis, prevention of preeclampsia and eclampsia, treatment of malaria in pregnancy. Okay, so these are all preventable. Treatment of infection, detection of breach, labor surveillance, clean delivery practices, breastfeeding. If you look at this list, it may look simple, but sometimes these are overlooked. Prevention and management of hypothermia, kangaroo care, newborn management, insecticide-treated materials, and complementary feeding. These are not just roles of doctors and nurses and midwives, but to be able to know, to tell the mother what to do is very important. Zinc supplementation, HIV vaccine, sanitation, and the like. Treatment of UTI, corticosteroids for preterm labor, resuscitation of the newborn, pneumonia management, oral rehydration therapy. So these are all done to prevent childbirths. Okay? And we have to approach this holistically. Okay? Know the age risk factor so that we know what to address so that we can avoid mortality. Okay? In conclusion, so maternal, neonatal, and child mortality has been very persistent in the global context. Now, 38% of all childbirths would occur in the first month of life. So more than 10 million children under 5 would die each year, and most would be preventable and treatable. That's saving 30,000 children a day. So most would be from developing countries and the like. Okay? So that would be our first lecture. Let's have the next. So this would be expanded program of immunization and breastfeeding. Okay. Okay, we have your expected program of immunization. So this would be some major changes. So Japanese encephalitis vaccine is now included in the recommended vaccine group. Okay. Quadrivalent vaccine would be the one recommended, and HIV recommendation for high-risk children are included in vaccines for high-risk special groups. But aside from it changing from expanded program of immunization to national immunization program. Okay. So this hasn't changed much. The childhood immunization schedule is such. You have um, learned this in pedia, but of course in community we also should know the vaccine schedule. Okay. Of course, you know that at birth, you have your BCG and hepatitis B. Then after 6 weeks, you have your 5-in-1, as they commonly call it. So that's your Hep B, your DTaP, your HIV, your OPV, IPV, and your PCV after 6 weeks. Then after 12 weeks, again, then so on and so forth. With the schedule, that would be up to end of reproductive age, which is 80. Okay. Uh, However, what is covered by the national government would only be up to 2 years old. More than that, it's out of pocket more often unless there's an ongoing program of government to provide for school children. Okay. So this is the schedule, as I have mentioned. BCG, hepatitis at birth. After 6 weeks, you give your pentavalent vaccine, OPV, and pneumococcal. After 2.5 months, you also give your 5-in-1, OPV, and pneumococcal. After 3.5 months, you give your IPV. After 9 months, you have your MMR, and at 1 month MMR. Unless there's an outbreak of measles, for example, um, there was a directive that you can give it as early as 6 months if during the outbreak wherein there were detected cases of measles some years back. Okay. National Immunization Program. So how is it done? So BCG is a single dose given at birth. Okay. Monovalent hepatitis B vaccine also given at birth. Okay. Your DPT, Hib, Hep B vaccine. So these are 3 doses given at 6, 10, 14 weeks of age. OPV as well, 6, 10, and 14. And a single dose of IPV is given with the third dose at 14 weeks. Okay. PCV is also given 6, 10, and 14. Rotavirus is given at 6 weeks with a minimum interval of 4 weeks between doses. Okay. Measles given at 9 months of age and then at 12 months of age. So this is like your table, but only in tabular form. Okay. Your school-based immunization program so that you can have catch-up doses for school children have been established. So this would be your boosters for your measles, rubella, and tetanus diphtheria given to grades 1 and 7 students, and these are for students enrolled in public schools. Okay. HPV, okay, given to children 9 to 10 years old at health facilities in priority provinces. So quadrivalent HPV, 2 doses are given at 0 and 6 months. Okay, for children less than 15, the dose would just be 2 compared to 3 doses. Okay. Japanese encephalitis is given subcutaneously. So this is given at a minimum age of 9 months. So children 9 months to 17 years of age should receive 1 primary dose, followed by a booster dose 12 to 24 months after the primary dose. For individuals 18 years and older should receive a single dose only. Okay. So this would be areas at risk for Japanese encephalitis. Okay. So this includes your India. Okay. So this is a study done with the epidemiology of Japanese encephalitis in the Philippines, showing the epidemiology of Japanese encephalitis cases in the Philippines. Okay. And it's endemic in the Philippines and responsible for 7.4 to 40% of meningitis encephalitis syndrome. So this affects children younger than 15 years old. That has a case fatality ratio 8.1 to 15.3%, and those who survive have significant neurologic sequelae. Okay, so there were lab confirmed cases of Japanese encephalitis, some 2011 to 2014. Okay, results from the surveillance. So the Aero epidemiological studies, swine and other animal surveillance, as well as mosquito surveys, confirm that Japanese encephalitis is and there is circulating all across regions of the Philippines. Okay. Trivalent influenza. Okay, there's trivalent, there's quadrivalent. The recommended would be your quadrivalent, which is given IM. Trivalent can be given subcutaneous or IM. Okay. Minimum age to give your influenza would be 6 months. Okay. The dose of influenza vaccine is 0.25 ml for children, 6 months to 35 months, and 0.5 ml for children, 36 months to 18 years. Okay. Children 6 to 8 years receiving influenza vaccine for the first time should receive 2 doses separately by at least 4 weeks. If just 1 dose is given during the previous influenza season, give 2 doses of the vaccine, then 1 dose yearly thereafter. So children aged 9 to 18 years should receive 1 dose of the vaccine yearly. Okay. Annual vaccination should begin in February or when the flu vaccine has been produced. More often than not, it appears April or May, depending on the production of the vaccine. High risk. You have your hip. So this is given intramuscularly. So this is given for children who are on chemotherapy, who is asplenic, HIV infection, immunoglobulin, or early complementary deficiency. A children 12 to 59 months or unimmunized with 1 dose Hib received before age 12 months, give 2 doses of Hib vaccine 8 weeks apart. If there are 2 doses of Hib before 12 months, give additional dose. Okay. For children more than or equal to 5 years old, who received a Hib booster dose during or within 14 days of initiating chemotherapy, treatment should receive a repeat dose of the vaccine at least 3 months after completion of therapy. The children who are also hematopoietic stem cell transplant recipients should be re-immunized with 3 doses of Hib 6 to 12 months after transplant, 8 weeks apart. So unimmunized children, age 15 months and older, undergoing elective splenectomy, give 1 of Hib containing vaccine at least 14 days before procedure. So give 1 dose of Hib vaccine on immunized children 5 to 18 years old who have anatomic functional asplenia and HIV infection. Okay. Dengue. Okay, not part of your EPI, but given to school children. So tetravalent dengue serotypes 1 to 4. It's a live attenuated vaccine given to 9 to 45 years. Dosage would be 0.5 ml given subcutaneously with 3 doses, 0, 6, and 12 months. Okay. So as I have mentioned, it's given to school children, 1 million children in 3 regions. Grade 4 pupils, 9 years and above, enrolled in all public schools. 3 doses of dengue vaccine will be provided at 6 months interval. Screening and quick health and consent. Okay, if you remember, some years back, um, there was a dengue vaccine scare. The problem was screening and health assessment was not properly done. Okay. What if there's a vaccine shortage? Okay, the Philippines experienced a vaccine shortage some years ago, and it affected countries, not only the Philippines, as well as ASEAN region. So what do we do for vaccine shortages? So, of course, we prioritize dosage. Okay. We follow the schedule as much as possible, ensure minimum intervals and minimum age. You have prioritized infant primary series over the first toddler booster over the preschool booster. Okay. Of course, you prioritize your first and second over your third dose. If supply is lacking, you can use a 2-dose regimen instead of 3 with 2-month interval between doses. Okay, so 2-dose primary series should receive booster at 11 to 12 months. Okay, hopefully no more shortage by a year. Okay, if there's an alternative available containing the same antigens, then 3-dose infant primary series is prioritized over 2-dose series. Okay. So what are the vaccine substitutions that we can do? Okay, so DTaP, IPV, Hep B, Hib. You can substitute with DTaP, IPV, Hib with Hep B, or DTaP, IPV with Hep B and Hib. So you don't have your pentavalent or your quadrivalent available, you can give it individually. Okay. DTaP IPV Hib, you can give your DTaP IPV with Hib or your DTaP IPV Hep B with Hib. Same way, DTaP IPV, you can give your DTaP plus IPV and Hib. DTaP IPV, you can give your TDAP IPV or your TD and IPV. Okay. If you do substitute, ideally you substitute with same brand interdose. So if you vaccinated with, for example, Pfizer, next should be Pfizer also. Okay. Flexibility. Ideally, you follow the schedule. Okay. But if you have delayed first dose, you should start the series as soon as you can. Okay. Second dose should be given as close to a 2-month interval. Okay. When you receive 2 doses with interval more than 2 months, but no available third dose may be omitted but should have your booster vaccination come to school. If less than 2 months, third dose should be given as soon as possible. Dose primary series. So this is as close to 24 months as possible. For 2-dose primary series as close to 12 months as possible. I'm separated pala. Okay, let's have, so that is Okay. That is immunization. Okay. And last lecture for this afternoon would be breastfeeding. Common breast concern. Okay. Common difficulties and maternal breastfeeding problems. Okay. We will not talk about breast production, etc., etc. You have learned that in pediatrics. You have learned that in obstetrics. Okay, we will learn more on common difficulties and breastfeeding problems and why it's difficult to actually breastfeed. Okay, and why systemically breastfeeding would not be a very lucrative thing to advocate for. Okay. Objectives to identify and describe common breastfeeding difficulties and problems of mothers, to discuss and explain how to manage common maternal breastfeeding difficulties, inadequate milk, like crying and a baby who refuses to feed. Okay. So we have common breast problems, flat nipples, sore nipples, engorged breast, mastitis. Importance of counseling skills in helping mothers with breastfeeding concerns. Okay. What do you think would be the most common reason why mothers discontinue breastfeeding? Anyone? Any idea? Any idea? Anyone? Any idea? Garima, Kalra.
Maybe the mother is having issues with weight, or else if the mother is having any taking medications.
Mothers taking issues with the baby, like having medications.
To generally speak, if the mother is working and if the area is uh, unsupportive, and if the mother is unable to carry the baby to the workplace, so that might be the reasons, doctor.
So let us look at issues. So they will say, not enough milk. Oh, my baby is not happy with the amount of milk that I'm producing. She's happier if I bottle feed her or bottle feed him because the milk is not enough. But the baby is crying. They cannot get milk from me. So we'll feed bottle. Does not want my breast. Would want to feed from bottle. Because structurally, it's easier to feed from the bottle than suck from the nipple. Okay. And if it's the first, and if it's the first thing that the baby encounters, then will really refuse your breast over something that is easier. Okay. So that's why when we deliver the baby, we do essential newborn care. And part of essential newborn care would be including early latching on. That is when you deliver the baby, you have not cut the cord, you latch it, you place the baby on the tummy so that the baby can latch on the mother's breast. And that's also part of bonding. Okay. Not enough milk. How do we think? Mother thinks she does not have enough breast milk. So it will normally produce 500 ml to 1000 ml. Baby does not get enough breast milk because ineffective suckling. Okay. Most will say if it's smacking sound, then the baby is getting enough milk. But the correct way of breastfeeding is a quiet, peaceful sucking. Okay? And positioning is very important. Okay, otherwise, the baby could not suck effectively. Okay. So it's either ineffective suckling or mother cannot produce enough milk. So these are factors why baby may not get enough breast milk. Okay, there was no latching on, so delayed start. So you have, especially for new mothers, they've read in baby books or they've read in the internet, it has to be every 2 hours. So what they do, now it's not yet 2 hours, so they don't feed the baby yet. So we play it by ear. You feed when the baby's hungry. So, or you don't feed frequently. No night feeds. Big mother is tired. So you don't feed at night. Short feeds, it gets interrupted. Poor latching on or poor attachment. Okay, start of bottles and pacifiers. You're already starting on other foods and other fluids. Or baby's sick or baby's abnormal. Okay. So that is physical breastfeeding factors. Mother, psychological factors. Some, especially most um first time moms, lack of confidence that they can breastfeed properly, worried that their baby might not get enough milk. They don't like breastfeeding because they say it will disfigure their breasts, rejection of baby, and of course, after childbirth, you're tired. So these are all also factors. That's why breastfeeding is for the determined. Okay. Mother, physical condition. Of course, your pills can affect the amount of milk that you produce. If you get pregnant again, if your mother is severely malnutrition, okay, alcohol, smoking, other conditions such as retained piece of placenta and poor breast development. Okay. So these are reasons why baby cannot get enough milk. And how can we address this problem? Counsel, 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 so that you know how to take feeding history and how the mother is approaching breastfeeding. Use observation. You use observation to check if the mother is feeding properly. So that you learn why mother has doubt, you can reassure her doubt and her feelings. Give praise for things that she's doing correctly and correct mistakes properly without scolding, without being sounding critical and judgmental. Okay. It takes for the determined to do breastfeeding. Okay. And arrange a follow-up soon. Okay. If your baby's crying, okay, possible reasons. Your baby's in discomfort, either dirty, soiled diapers, or the place is cold, or too hot. Okay. Baby could be tired. Too many visitors. Okay, it may sound harmless, the viewing of the baby, oh, you're so cute, etc., etc. But your baby gets tired as well. Of course, if your baby's ill, so you will notice a change pattern of crying. And if your baby's really not getting enough milk, okay, baby will cry of hunger. So again, counseling skills, assess the baby, praise when relevant, empathize, and give relevant information. Okay? Give practical help. And how can you help? Okay. So you give advice on decision, you give advice on what to do, how to wake up, especially if you've been there. And refusal to feed, possible reasons. Illness, changes which upsets baby, such as separation, there's a change of the carer, refusal, age 4 to 8, easily distracted, above 1 year, the baby will self-wean. Okay? In summary, okay, so practice listening and learning skills. Okay? Listening to your mother who is breastfeeding. Support your mother's confidence and support skills. Okay. That is breastfeeding. Do direct observe breastfeeding observation. Help mother to position and attach her baby. And take a detailed feeding history. Okay. So these are breastfeeding problems. Okay. This is your inverted nipple. No nipple to latch onto. Okay. Large, small breasts. So various positions to support her baby. So sometimes you could go side, so that would be easier. If you're flat inverted nipple, you can do cup feeding. So baby sucks from the breast, not from the nipple. because if it sucked from the nipple, it would be painful. So you suck the breast so that milk will come out from the nipple. Okay. So if you have long or big nipples, use the underarm position. So in your arms would be in a C position, cup feeding using expressed breast milk. Okay. Reassure that the mother baby's mouth will grow eventually and nipples will not. Okay. At first, it will look small. Okay. So this is your nipple different forms. So you can pinch your nipple so that it would elongate so that the baby would have something to latch onto. Okay. So that's just the management of flat inverted nipple. As early as antenatally, you do treatment and counseling so that you build the mother's confidence while the baby is in the womb. Okay. You have your underarm position. If baby can suck in the first week or two, help mother to try the following. So you do cup feeding and soften the breast before attaching to the breast. Okay. Sometimes you use a syringe to extract the nipple. So you pull the plunger to maintain steady pressure. Do it for 30 seconds to 1 minute several times a day. So push the plunger back to reduce suction if it's painful. So you cut the tip end so that it will end with just the plunger, no tip. Then you will put that on the nipple and then you suck. So the effect would be there would be pulling of the nipple outward. Okay. Another cause would be causes of sore nipple. Okay, there would be poor attachment, candidiasis, not properly positioned pump, too much stretching of nipple caused by the pump or wrong position. Okay. Management of sore nipple. Okay. How do you manage sore nipples? So you observe the feeding session, reassure the mother, help improve attachment and positioning, treat skin condition such as the fungus, soreness, either if it's a big, small lesion or a short frenulum. Okay. What conditions are these? So this is breast that will be not expressed milk. So milk has come in but not has been let out. So it's hot, heavy, and hard. Milk is flowing but lumpy. Okay. So you feed frequently. Okay. This one is an engorged breast. Breast is over full, filled with milk. Partly with increased tissue fluid and blood, interferes with milk flow and breast is shiny and edematous. So this one's painful. Milk does not flow well, nipple is stretched tight. Okay. How will you prevent engorgement? You breastfeed soon after delivery. You ensure good attachment. You encourage on-demand feeding. Okay? Or if the baby is not able to suck, you do express milk. So how do you manage engorged breast? So you stimulate your oxytocin reflex by warm compress. Okay. You massage the back or the breast nipple or skin. Make the mother relax. Take a warm shower and bath. And after feeding, put cold compress to help reduce edema so that you can build mother's confidence. Okay. So HIV, okay, unless needed, you should express milk only to relieve congestion and not to increase production. Express only when breasts are overfull to make her comfortable. You may give analgesics to relieve inflammation and discomfort. How about this one? What condition is this? Okay, so this is what we call mastitis. So there's block, duct, and reduce and resulting to mastitis. So there's poor drainage of the whole breast. So there's infrequent feeds due to ineffective suckling or pressure from clothes, pressure from fingers, large breasts that are draining poorly. Sometimes because there's reduced frequency of feeds, there's damage to tissue, there's bacteria because you have a cracked nipple or trauma to the breast. How we treat to improve drainage of milk, identify cause, and correct. So we avert this by frequent feeding or rest, do your gentle breast massage, do warm compress, start feed on affected side if in pain, express if necessary, and change feeding position. Of course, you give your antibiotics, your cloxacillin, or your analgesics for pain. Of course, if you have mastitis in an HIV infected mother, you avoid breastfeeding on that side with infection. This one, what do you notice about this breast? So this one is not only mastitis, but it has also abscess. Okay. Again, how do we help a patient with breast abscess? You give your antibiotics, you give warm compress so that you can reassure the patient. You can still continue breastfeeding depending on the site of the abscess, if it's in the areola or in the breast. Or you can just express the breast milk. Okay. This one is candidiasis. So this is a whitish, scaly, flaky lesion and gives severe pricking-like sensation when baby is suckling. And this is treated with antifungal cream applied evenly for better absorption, preferably after feeding. Okay. So you have a shiny red area, which is sore, flaky, burning, continues after feeding. So check for baby for fungal infection inside the mouth or diaper rash. Treat breastfeeding, both mother and baby. Okay. Okay. Treatment is with nystatin cream. either a suspension, avoid using or stop using pacifiers, teats, or nipple shields. Okay. In HIV infected women, treat breast thrush and infant oral thrush promptly. Okay. This one. So an equal breast. Okay, this is due to belief that you always start breastfeeding on the right because it contains milk and the left contains water. Or there are breastfeeding myths also that you have to correct. So explain what you want to do. Ensure privacy. Ask permission before you do your breast exam. Talk to the mother first and look at the breast without touching. If you do need to touch, do it gently, especially if it looks like it's really infected. Okay. So again, if every finding that you see, explain what you found, highlight the positive signs, don't sound critical about their breast, build her confidence in her ability to breastfeed, and thank her for her cooperation. Okay. In summary, the most common reasons why mother discontinue breastfeeding are not enough energy, a crying baby, and a breast refusal. Okay, to help mothers with breastfeeding concerns, health workers must practice listening and learning skills, build mother's confidence, take a detailed history, and help make mother position and attach their needs. Okay, and the most common breast problems are breast forms, sore nipples, engorgement, block duct mastitis, and breast abscesses. Okay, so breastfeeding is for the decided. Again, your systemic political structure also prevents people from being advocates of breastfeeding. Why? Because your formula milk is supported by multinational companies. And of course, these multinational companies would do everything in their power to promote their milk so that you will buy them. And who will promote breastfeeding when there's no profit margin associated with it? Although it has been proven that it is the most cost benefit shall activity that one can do after delivery. It's the most nutritious fluid for the baby. However, we have our multinational companies that we are up against because, of course, if it's profit driven, your capitalist society would want you to increase consumer spending. Okay? And that's why breastfeeding finds it hard to take off. Okay. Sometimes it's even the pediatricians who will smuggle the breast milk, the formula milk inside the hospital, or they will be the ones recommending the formula milk in the hospital. Why? Because again, there's no free lunch. There are exchanges for that. But as much as possible, breastfeeding, it's most nutritious and it's cost beneficial for mother and baby. Okay? That's our lectures for this afternoon. Any questions? Okay, if you want to go back to this lecture, I've uploaded the link in our YouTube channel so that you can study it prior to your exam. Okay, if you don't have any questions, you may leave this call. Thank you.